Okay, I think we're good to start. So good afternoon, good evening, good morning, everyone joining from different parts of the world. My name is Muhammad Yaqub. Today I'm going to be the host for the industrial talk given by Dr. Yan-Jie. And before we start the presentation today by Dr. Zhou, I would like to ask everyone to, if you have any question, please feel free to add your question to the chat, to the Q&A box. So you should be able to see a Q&A box. And so we will take these questions at the end of the session. So Dr. Zhou will be presenting for 30 to 40 minutes. And following that, we'll take some of the questions that you write on the Q&A box. Please use the Q&A box rather than the chat box. So before we start, let me introduce Dr. Zhou. So he's a staff algorithm expert in Alibaba DAMO Academy. He's a technical leader in chest pain triple rule out of research at DAMO Academy. He obtained his PhD from the Institute of Automation, Chinese Academy of Sciences, and he has published papers and abstract on Nature Medicine, IEEE Transaction of Medical Imaging, CVPR, MICCAI, and more. He has received multiple awards, including the Excellent Technology Project Award at Alibaba DAMO Academy, the President Award of Excellence at Chinese Academy of Sciences. His research mainly focuses on robot-assisted intervention and medical image analysis, especially on disease screening and diagnosis in CT images using deep learning. Without further ado, we're glad to have you, Dr. Zhou. Over to you.
Thank you. And good morning, good afternoon, good evening, everyone. My name is Zhou Yan-Jie, and I'm from Alibaba DAMO Academy Medical AI Lab. And thank you so much for the invitation. Today, I'm excited to share with you our recent work on AI-based rapid and accurate warning of acute aortic syndrome from non-contrast CT. And this work was recently published in Nature Medicine. Firstly, what is acute aortic syndrome? Acute aortic syndrome, AS, refers to a group of life-threatening aortic emergencies, including AD, IMH, and PAU, three subtypes. And AD is the most common form of acute aortic syndrome. It happens when a tear forms in the inner layer of the aorta, allowing blood under high pressure to surge into the wall of the vessel. This creates a forced channel or a forced lumen alongside the normal blood flow path, splitting the aortic wall into two layers. IMH is a type of AS where blood leaks into the wall of the aorta, usually from a ruptured small vessel or an ulcer, but without a tear in the inner lining. And then PAU often causes a localized IMH. Under the existing emergency clinical pathway of chest pain, even top hospitals in China have continuously occurred medical errors resulting in the death of patients with acute aortic syndrome due to various reasons. The incidence of chest pain is about 15.5 per 1,000 people, and it is the second most common reason for adults to present to the emergency department. And about 0.09% of patients with acute chest pain are finally diagnosed with AS. And in practice, AS is a very deadly, rare, and extremely challenging emergency diseases to be diagnosed. The effective treatment time window of AS is very short. In the acute phase, about 33% of patients die within 24 hours, and 50% die within 48 hours. The misdiagnosis or misdiagnosis rate of AS is as high as 38%, since many doctors in primary hospitals have a serious lack of understanding of AS. The main reason for this clinical situation is a large number of patients who present to the emergency department with chest pain, but their chest pain symptoms are usually nonspecific or minimal. However, AS is a rapidly developing syndrome with involving signs, symptoms, and clinical state. Unfortunately, there is no simple and dedicated triage tool for AS at present, like ECG for ACS or D-dimer test for PE. It is difficult to identify patients with a high suspicion of AS based solely on clinical symptoms and preliminary investigations. In the clinic, Aortic CTA is a gold standard for the diagnosis of AS. The potential of using non-contrast CT for screening AS has been explored previously, and it is often performed as a standard practice along with contrast CT for the purpose of better visualized for IMH. The diagnostic performance of non-contrast CT alone, however, has not been well reported in prior studies. In China, when patients coming with acute chest pain, non-contrast CT is often the first scan they get, even for cases that later turn out to be AS. Why? Because doctors are usually trying to quickly rule out more common causes like pneumonia. This is partly due to how our healthcare system works. We need to balance speed, cost, and patient flow in busy emergency departments. Of course, if a life-threatening condition like ACS, PE, or AS is strongly suspected, clinicians will go straight to contrast CT to confirm. But if the suspicion is lower, they will often start with non-contrast CT because it is faster, cheaper, avoids unnecessary contrast, and helps reduce overcrowding. However, as we can see in the figure, the fourth lumen is very clear in the CTA image. We can see here, but almost cannot seen in the non-contrast CT image. That is exactly why we built an AI system that works directly on these non-contrast CT images to catch AS early, even when it is not the top suspicion. For chest pain patients with a high suspicion of AS, the initial image mortality in China is exactly the same as that in the international guidelines. We can see from this figure that emergency clinicians split patients into two groups based on initial assessment, those with high suspicion of AS and those in whom AS is unlikely but other conditions are suspected. As we can see, if AS patients are suspected of having other acute diseases in the first triage, they will experience multiple rounds of investigations, including various non-contrast examination. Recent advances in deep learning methods have demonstrated superior capabilities in extracting and identifying latent and clinically relevant features from medical images. So, on the premise of following the existing clinical pathway, the non-contrast CT images of different particles generated in the clinical process were fully utilized by AI. iAorta can identify AS rapidly and accurately on non-contrast CT scans in real-world emergency settings and provides early warnings of AS to radiologists. In this way, iAorta can be seamlessly integrated into the existing workflow for emergency department. And this is an overview of our pipeline. To obtain accurate diagnosis predictions and segmentation results, we collected 3,350 aortic CTA scans, including arterial and non-contrast phase series, to train the model. The arterial phase series were used as a gold standard for diagnosing AS and stressing lesion areas, while the non-contrast phase series were used for model training under the supervision of the diagnostic labels and the segmentation labels that are transferred by image registration methods DIS from annotations on paired arterial phase series. The output of our model are AS classification results at the patient level and the segmentation mask of aorta and true lumen. Furthermore, we generated activation maps by mapping the normalized activation scores to their corresponding spatial location in each CT slice. In our task, the regions with high activation scores typically corresponded to relevant abnormal areas, whereas the low activation scores indicated healthy aortic areas. The regions with high activation scores in each slide provide variable visual information for AI-assisted detection of AS in the ED. The DR model consists of two stages. Given that the input of a non-contrast CT scan, we localized the aorta at the core stage and then detected possible AS at the fine stage. And in the core stage, we trained an NU net to segment the whole aorta from the input non-contrast CT scan. And in the fine stage, the network is based on multitask learning strategy. For segmentation, two different decoders that have the same architecture sharing the same encoder aim to learn some general feature representation from the encoder and the unique representation of aorta decoder A and the true lumen decoder T. The architecture of the two decoders is the same as that of the decoder in 3D NUNet. And we trained a joint segmentation and classification network to segment the aorta and the true lumen and classify AS or non-AS. Furthermore, a generation of activation map is based on a distance map that depicts the distance from each voxel in an image to a specific object or feature. In detail, the construction of a distance map involves calculating the distance of each true lumen voxel to the nearest voxel representing the boundary of the aorta by applying Euclidean distance transform. Voxels that are closer to aortic wall have smaller values, whereas those farther away have larger values. By analyzing the distance map, the slice level and voxel level locations of the lesion within the aorta can be determined based on the different values assigned to different voxels. As a result, the model is capable of determining the specific slice corresponding to the AS lesion and the precise location of the lesion within the slice, visualization and enhancing the interpretation of the proposed model. And we have also developed an innovative early warning system being specifically designed for rapid and accurate detection of AS in real-world clinical medical settings. This system integrates an AI non-contrast phase selection tool or developed AS model and a user-friendly warning pop-up plugin to process and analyze vast amounts of patient data in real time. By leveraging these cutting-edge technologies, our system enables radiologists to receive timely and precise alerts, facilitating informed diagnosis and prompt intervention. Seamlessly integrating these components into iAorta system not only enhances the efficiency of our diagnostic workflow, also significantly improve the patient outcomes by reducing the time to proper clinically critical decision making. And the non-contrast phase selection tool is a vital component of our iAorta warning system, using deep learning methods to automatically identify and classify distinct phases within a CT scan, including non-contrast, arterial, venous, and delayed phases. And the warning pop-up plugin is another crucial component of our warning system. After the CT phase selection tool has processed the images, our DR model evaluates the data for the presence of AS. Upon detection of any anomaly, the plugin instantly generates a real-time alert, which is displayed pop-up on the radiologist screen. And here are some visualization results. And there is visible difference in the appearance of activating maps between different subtypes. The high activation regions of TAAD, TBAD, and IMH are more refined and larger, whereas those of PAU are coarser and smaller. This observational is consistent with their representations of subtypes. And our model demonstrates strong performance across all AS subtypes, effectively highlighting the location of potential lesions. And we conducted a comparative experiment with other state-of-art models on the dataset via five-fold cross-validation. Among them, CMT-GF is one of the best detection methods for detecting aortic dissection on non-contrast CT images. Performance was assessed using AUC along with sensitivity and specificity as the optimal operation threshold. Compared with these methods, iAorta achieved the best classification performance. Then we designed a stepwise study in 4 stages with 9 hospitals across China to validate the iAorta system for effective detecting AS. Stage 1, 2, and 3 are retrospective study, and stage 4 is a prospective study. In stage 1, we evaluated the model in In stage 1, we evaluated the model in an internal validation cohort and 7 external validation cohorts. In stage 2, we compared the model performance with radiologists of varying expertise levels and radiologists assisted by AI on non-contrast CT. In stage 3, we evaluated the model's robustness across various non-contrast CT protocols. And in stage 4, we integrated iAorta system into the existing clinical workflow to achieve practical clinical application in 2 prospective trials. A prospective multicenter study, including comparative analysis and a pilot deployment, were conducted to assess the feasibility of integrating iAorta into the real-world emergency department workflows. And okay, in the stage 1, we collected 20,750 aortic CT scans, including arterial and non-contrast phase series similar to those used in model training from 8 hospitals across China. And we can see in this internal validation cohort, the overall model performance in detection AS on non-contrast CT achieved a sensitivity of 98.4% and a specificity of 94.7%. And in the external validation cohorts, iAorta achieved a sensitivity of 95.4% to 97.5% and a specificity of 92.9% to 94.6% for AS detection. Overall, the system demonstrated a mean sensitivity of 97% and a mean specificity of 94%. Furthermore, we conducted a subgroup analysis performance for different subtypes of AS. The model achieved a sensitivity of 97.1% to 99.5% for TAD, 98% to 99.6% to TBAD, and 95.3% to 98% for IMH, and 91.2% to 95.5% for PAU, respectively. In summary, iAorta achieved robust performance across all AS subtypes in 8 validation cohorts. In stage 2, we recruited 11 radiologists with varying degrees of expertise, including specialty experts in cardiovascular, broader certified general radiologists, and medical trainees to participate in this study. In the first step, radiologists were asked to independently diagnose each case, AS or non-AS, without assistance of iAorta. After a 2 months washout period and randomization of the data, in the second step, the same group of radiologists were given the segmentation results and abnormal probabilities of iAorta to assist in their assessment of diagnosis again. And the performance values of all 11 radiologists in either independent diagnosis or with AI assistance were lower than those indicated by ROC curves for model alone. Independent diagnosis, the sensitivity levels varied greatly among the 11 radiologists, with 80.7% for specialty experts, 77.8% for board certified radiologists, and 60.3% for medical trainees, which was significantly lower than that of model. When radiologists were assisted by model, the sensitivities of specialty experts, board certified radiologists, and medical trainees all increased significantly, reaching 94.3%, 89.8%, and 91.9% respectively. For detecting AS from its specific subtypes, the mean sensitivities of radiologists were 70% in TAD, 74.1% in TBAD, and 64% in IMH, which was significantly greater than the score of 38.2% in PAU. With AI assistance, the mean sensitivity of radiologists improved significantly, reaching 89.3% in TAD, 94.1% in TBAD, 85.9% in IMH, and 73.8% in PAU. These results demonstrate that AI assistance remarkably enhanced radiologist performance in all subtypes. In summary, we got 2 major findings. The first one, the sensitivity and specificity of our iAorta exceeded the level of specialty experts. The second one is the iAorta can improve the sensitivity of medical trainees by more than 40%. And in the first two stages of our clinical study, we evaluated iAorta using non-contrast CT scans from high-quality Aortic CT protocols. These scans typically offer excellent image quality and full aortic coverage, representing a relatively ideal scenario for model validation. And starting from stage 3, we shifted our focus to real-world clinical deployment. To better reflect the complexity of emergency practice, we significantly broadened our test data to include any non-contrast CT scan covering part or all of the aorta. This includes routine chest CT, abdominal CT, rib CT, and other common emergency scans. This expansion allows us to assess iAorta's robustness in diverse clinical settings, where scan coverage, image quality, and acquisition protocols vary significantly. In stage 3, we collected 137,525 consecutive patients with acute chest pain in emergency departments of 3 hospitals. iAorta achieved the mean sensitivity is 92.6% and the mean specificity is 99.2%. And the bottom figure shows the model performance metrics, AOC, accuracy, sensitivity, and specificity for AS detection across 3 subtypes: non-contrast chest CT, non-contrast abdominal CT, and others. And these findings demonstrate that our model consistently achieved robust numerical performance results under various CT protocols. Furthermore, we evaluated the potential clinical value of our proposed AI model in identifying AS patients. In China, initial diagnosis by emergency clinicians was based on preliminary investigation using age, risk factors, history, pain characteristics, findings on physical examination, ECG, and some lab tests. In this study, 127 patients with AS were suspected of having AS after the initial assessment, and the remaining 121 patients with AS did not initially receive the proper and correct initial triage decisions from emergency clinicians, and subsequently performed other CT protocols examination as the initial imaging rule test. Applying our iAorta would help diagnose 109 patients with AS, which could reduce the risk of misdiagnosis from 48.8% to 4.8%. And on the other hand, the AI model missed a total of 12 cases, 11 were PAU and 1 was limited IMH. And stage 4 is a multi-center prospective study. We first conducted a comparative study to assess the feasibility of the iAorta system. As an observational study, AI outputs did not influence or change clinical management or patient outcomes. We established 2 parallel groups. Group A independently reviewing images mirroring the current clinical workflow, and Group B assisted by iAorta conducting the same task. In detail, in the first group, Group A, the radiologist team consisting of the initial reporting by junior radiologists and the report reviewing by senior radiologists, independently evaluated the images in a sequential manner within the current clinical workflow. And the second group, Group B, is a matched control group with an identical workflow and environment. But with the iAorta AI system, the diagnostic assessments in Group A and Group B were completely independent. Under the above experimental protocol, we evaluated 30,846 emergency patients presenting with acute chest pain, among whom 11 were initially not suspected of having AS and underwent non-contrast CT scans. As shown in the results, junior reporting radiologists with AI assistance improved the sensitivity from 21.4% to 78.6%, and specificity from 98.3% to 99.1%. The senior reviewing radiologists also saw gains. Sensitivity increased from 42.9% to 85.7%, and specificity from 98.9% to 99%. Overall, under the standard clinical workflow, Group A, the radiologist team correctly identified only 2 out of 11 AS cases. In contrast, the iAorta system alone detected 9 cases, missing only 2 non-critical cases. When assisted by iAorta, the clinical team achieved a substantially higher sensitivity, demonstrating the system's potential to reduce misdiagnosis in real-world emergency settings. More importantly, integrating the iAorta system into the current diagnostic workflow reduced the average time from admission to correct diagnosis pathway for AS patients with initial false suspicion, significantly from an average of 3.85 hours down to 1.03 hours, which could reduce the diagnostic window and enabling earlier intervention. And here is a typical case from the study. A 71-year-old male patient with a 28-year history of hypertension was admitted to the hospital for examination due to abdominal pain for 7 hours. Physical examination and ECG showed an anomaly. The patient was first examined by abdominal non-contrast CT scan. The radiologist did not find any anomaly. Then the patient's pain had shifted, and a chest CT scan was performed. The radiologist who reviewed the report noted widening the aortic arch and recommended Aortic CTA. The time from admission to correct triage was 4.55 hours. In the parallel control group, Group B, with the assistance of our iAorta system, during the first abdominal non-contrast CT scan of the patient, anomaly could be identified by the radiologist, and the correct diagnosis and the treatment path could be entered in only 56 minutes, less than 1 hour. Our iAorta system demonstrated outstanding performance in an observational controlled trial, which motivated us to launch a single-arm study. In contrast to the observational setting, where AI outputs were used only for evaluation, this interventional study allows the AI findings to directly influence clinical decision-making and patient outcomes. In detail, iAorta processes non-contrast CT scans from PACS in real time. Upon detecting a suspected AS, it instantly triggers a pop-up alert to notify both initial reporting radiologists and report reviewing radiologists on duty. Under the above experimental protocol, we evaluated 15,584 emergency patients presenting with acute chest pain, among whom 22 were initially not suspected of having AS and underwent non-contrast CT scans. As illustrated in the figure above, nearly 56% of patients presenting with acute chest pain underwent non-contrast CT scans. With the aid of prompt and accurate warnings from iAorta, radiologist team successfully identified 21 out of 22 AS patients among a cohort of consecutive 15,584 patients. 1 PAU patient was missed. The AS identical performance reached an exceptional level with a sensitivity of 95.5% and specificity of 99.4%. And more importantly, the mean time to diagnosis for these 21 patients was under 2 hours, representing a 60.5% reduction compared to the median diagnosed time of 4.3 hours for type A aortic dissection reported in circulation. By enabling earlier detection, iAorta not only advances the diagnosis and the treatment window for AS, but also has the potential to reduce adverse events and improve the patient outcomes. And here is another example. A patient presented to the emergency department with the right upper abdominal pain Following an initial assessment, the clinical suspicion of an abdominal emergency was made, and that led to the ordering of a non-contrast abdominal CT. About 1 minute after the images were uploaded to the PACS, iAorta issued an early warning to the on-duty radiologist via a pop-up alert. And after a clinical team discussion and an informed consent was obtained from the patient, an aortic CTA was performed, which revealed a Stanford type B aortic dissection. While the patient initially entered incorrect diagnostic pathway, the early accurate warning provided by iAorta ran on the non-contrast CT and enabled the final definitive diagnosis of AAS within 94 minutes from hospital admission, ensuring both timely and accurate patient management. In the following demonstration, let's pause here. The following demonstration represents a pilot deployment of iAorta in one hospital. As we can see, there are so many patients who need to be reviewed by radiologists. And iAorta automatically processes large amounts of input CT images from the hospital PACS, then identifies patients at risk of AS and provides pop-up alerts to the on-duty radiologist if positive. And radiologists click up the pop-up plugin. They can see the anomaly probability, auto mask, and the true lumen mask in the interface. In this way, the system enables radiologists to allocate their time and attention to the critical cases as the earliest possible, thereby optimizing the overall clinical workflow. In summary, iAorta offers two key contributions and potential clinical benefits. Firstly, in resource-limited settings or institutions with high patient volumes, non-contrast CT remains a commonly used initial imaging modality due to its rapid availability, lower cost, and reduced complexity. In settings where non-contrast CT remains the unavoidable initial or only image modality, iAorta can evidently help reduce delayed or misdiagnosis of AS. And by providing accurate, rapid, and interpretable warnings, iAorta facilitates timely and informed AI-assisted clinical decision-making, particularly in resource-constrained environments or regions. Secondly, differences across centers notwithstanding, as few as 2.7% of CTA examinations performed for suspected AS were true positive patients in an ED-based series. In facilities utilizing multi-phase like non-contrast CT and post-contrast CT protocols for AS evaluation like Hong Kong, iAorta's high sensitivity and high negative predictive value on non-contrast CT scans can potentially help avoid unnecessary contrast agent injections in low-risk younger patients. This not only minimizes the potential risks associated with contrast agents, but also reduces the additional radiation dose from post-contrast CT scans, enhancing patient safety and optimizing resource utilizations when permissible. This work was co-supervised by Dr. Zhang Hongkun, Professor Xu Mingfeng, and Professor Lu Le, and Dr. Hu Yujian and I are the first authors. Thank you.
Thank you very much for the exciting and interesting talk, Dr. Zhou. So please, if anyone has any question, write it on the Q&A box. We have a couple of questions already, but for everyone else, if you have any question, feel free to write. And thank you for so interesting. Honestly, I know the different work the team has been doing amazing work on the use of non-contrast CT in AS, but I know that there is also a lot of great work on cancers like pancreatic cancer, esophageal cancer, and other type of cancer. So a really great type of work. Let me start by the first question. So the first question is, if you remember in your presentation, you had 2 decoders. So the question is why the network needed, what's the second decoder for?
Okay, let's go to the slide for the decoder introduction. Okay, here. The first decoder A is for the aorta segmentation, and the decoder T is for the true lumen segmentation.
So did you do an ablation to see like if this actually provide better performance?
Yeah, if we only use one decoder, maybe the true lumen segmentation performance is not good. Yeah.
Okay, thank you. So the second question is regarding the training data set, are the ground truth mask and the AAS label from the manual segmentation, or was it maybe semi-automatic? So is it manual segmentation for the training set?
Sorry, I don't get the point.
So when you did the training of the unit, you used the like segmentation mask for the supervision, right?
Yeah.
Was this mask created by a human or semi-automatic or fully automatic? What type of annotation you've done?
Okay, the annotation we do is on the arterial faces of the CTA scans, and or we have two senior radiologists independently annotate the labels, and the dice score between original CTA annotation and transfer mask need exceed 95%. So if while no registration is perfect, we believe the label quality is sufficient for robust training, and the high external validation performance supports this.
Sounds good. Next question, which I also actually have this sort of in my mind. The question by Ding, he says, he or she says, I noticed that your model structure is quite simple. You used unit or form of an unit as well. Could you explain how you achieve such high performance and strong generalizability with this simple architecture?
Well, it is a very good question. I think first we have built the largest AS dataset at present, encompassing a wide variety of cases, including AD, IMH, and PAU. And secondly, we carefully define a set of highly related tasks, the aorta segmentation, the true lumen segmentation, and AS anomaly classification. And these tasks are normally, I think these tasks are mutually beneficial when training jointly. And together, they enable robust detection across all major AS subtypes, including IMH and PAU, which lacks false lumen. And thirdly, although the anomaly are often challenging for the human eye to discount the non-coherent CT, but there is actually a statistical significant difference in HU values between the true lumen and the surrounding structures. This means the underlying signal is present. The task is not difficult. Yeah.
Thank you for the answer. I think we can probably conclude that even after 10 years and 2 weeks of presenting unit at MICCAI 2015, it's still a very powerful way to do segmentation if you perfect your data and your annotation. Thank you for the answer. Next question, I think we'll have like 2 more questions and we'll close the session. In the subgroup analysis results from the multi-center retrospective evaluation, why is the sensitivity for PAU relatively low?
Well, the challenge with PAU lies in both imaging physics and pathology. Unlike AD or IMH, often cause visible aortic wall thickening or contour deformity on non-contrast CT. PAU typically presents as a small focal ulcer with minimal wall disruption, sometimes invisible even to the expert radiologists. And in our stage 2 study, radiology activity in ideal settings. The fundamental low contrast to noise ratio of PAU on non-contrast CT remains a hard limit. Yeah.
Thank you. Next question is, since the ultimate goal of medical AI is to assist doctors in providing better care, have you received any interesting feedback or evaluation from doctors during the deployment of the application? How has their experience been so far?
Yes, we conducted a post-study survey with on-duty radiologists, and more than 90% of radiologists reported that the iAorta were helpful for or very helpful. And we believe radiologists found iAorta helpful primarily for two reasons. The first one is iAorta provides reliable early warning for AS, which gives them the confidence that critical cases won't miss. And the second one is the system is fully integrated into their exciting work, their workflow. It runs silently in the background, so it adds safety without adding burden. Yeah.
Thank you. So next question is about the data. Is it publicly available?
Sorry.
Is the data publicly available?
We can only open a small amount of data.
Makes sense. And maybe on that, is the plugin is the plugin available? Is the model itself publicly available or not?
Sorry,
The model weights. Are the model weights publicly available? The model weights.
Yes, sure.
It is? Okay, fantastic. So I guess we're gonna find it in either Hugging Face or GitHub somewhere. Next question, I think, and then last two questions, and then we'll stop. Did you also do any severity score estimation? How severe the anomaly is?
Yes, all activation map are not based on GradCam. Instead, they are derived from the distance transform between the segmented true lumen and aortic wall, as described in slide maybe 7 here. This approach provides anomaly meaningful localization voxel farther to the wall, where dissection or heminoma typically occurs, receive higher activation scores. We found this more interpretable and clinical aligned than the gradient-based silency maps, which can be noisy on non-contrast CT. Yeah.
Okay. So there is a correlation between these heat maps and the severity of the condition.
Yes, this activation map is based on the segmentation mask.
Okay, so last question is, can you give more details on the structure of the model? You mentioned using an unit. Does that mean your encoder is ResNet?
Okay, we use the ResNet 50 as a backbone.
Okay, so it's a ResNet 50 as an encoder and a couple of decoders. I guess that's the answer to Hassan's question.
Yes.
Okay, I think we're done with the questions. I think I would like to really thank you for the great work. I'm impressed by the amount of evaluation you do. When you evaluate, you don't just evaluate as many of us do. When we do a research paper, we have like say a set of a few hundreds of patients that we evaluate on. You evaluate on a crazy amount of cases, which makes people believe that this is likely to be generalizable. My one question before we finish: do you think you will have issues when you roll it out to different ethnicities outside China? Would it work? Do you have any thoughts on that? Do you have a plan to assess outside the China?
Yes, of course. We plan to do more study and evaluation on the European and US data. Yeah.
Okay, I look forward to look at the results at some point. So I think with that, thank you very much for your great talk, and I really enjoyed it. And thank you for everyone who joined us today. We look forward for our next industrial talk at MICCAI, and have another great speaker. Thank you very much, everyone, and have a good evening, morning, whatever time you are in. Thank you, Dr. Yan.
Thank you so much. Bye-bye.
Thank you. Bye.